thank you all for inviting me to be part of your speaker forum here. I'm very passionate about this topic, and I'm going to be giving a very broad overview of virtual reality techniques as they might apply in the rehab setting or in the broader medical setting. And I want to start, as you mentioned, we had Dr. Skip Rizzo as one of our speakers at the Empowerment series in October, and he really is one of the pioneering people in this movement, and he is a good friend of mine and has loaned me some of his slides. So in particular, the slides where you'll see some fun videos, those are his, and I just pay complete homage to him for those. And I also have contact information for Dr. Rizzo for any of you who might have technical questions about the various technologies and VR platforms, as he would be the one to be able to answer those questions. The technical stuff exceeds my knowledge. This is a picture of the USC Institute of Creative Technologies, ICT, as it's fondly referred to, and this is where all the magic occurs. Now, virtual reality is one of those things that's very difficult to define, and there has been much debate in the literature as to how to define it. And this is one of the simplest early definitions. It's a way for humans to interact with computers and extremely complex data in a naturalistic fashion. Or the more technocentric definition, and I'm going to read this one because it's very involved. Virtual reality integrates real-time computer processing, has interface technology, body tracking, and sensory displays to support a user to interact with and/or become immersed in a computer-generated simulated environment. That's a mouthful. Within such controllable, dynamic, and interactive 3D stimulus environments, behavioral action can be motivated, recorded, and measured. So that's jam-packed with a lot of information that really shows how there are so many assets with virtual reality that make it something that would be wonderful if we can integrate it into our services. This really kind of embodies how we're becoming one with our computers and our technology. Now, this is a brief overview of what we're going to talk about today, or try to get through today. We're going to kind of go into some introductory remarks about the assets of virtual reality. We're going to talk about some psychological treatment, which is really has gotten a lot of literature behind that. We're going to talk about virtual reality in motor and cognitive functions, and we're going to talk about pain management as well. There are other applications that are interesting and exciting. There's interactive opportunities with interactive humans, and so they're getting a lot of interest right now in terms of working with the Department of Defense. In the military, there are therapists who are kind of artificial humans that are providing some remote therapy with some of the veterans. There are opportunities with tele-rehabilitation using artificial humans, and that's another thing that is beyond the scope of what we're going to talk about today, but I just wanted to let you know that also is out there. So why virtual reality? Why all the fuss? Well, this starts with kind of one of the basic concerns with rehabilitation, and actually many types of treatments. We have limitations in the ecological validity of what we do. This is one of the most consistent concerns with rehabilitation. We also have limitations in generalization outside of the tasks that we're working on. Does this generalize to real-world functions and activities? And so virtual reality really brings a lot to the table to address these concerns. Virtual reality offers many new opportunities for advancements of research, assessment, intervention tools. It allows for approaches that would be difficult, if not impossible, to deliver when using traditional methods. There are some riskier things that we can try virtually than we could try in real life. Innovative options are available to actually target some of the cognitive, psychological, and motor functions depending upon the clinical health condition. And there's now a lot of research behind these techniques showing just a good track record of success. This is an example of all the applications that we have seen in the literature so far. Initially, it was developed to address simple phobias, spider phobias, height phobias, and now it is generalized to empirical literature looking at addiction, ADHD, Alzheimer's, autism, balance disorders, CP, neglect, pain, phantom limb, PTSD, stroke, other CNS issues, many more than we can cover. So per the definition, it allows for a very precise presentation and control of stimuli, which we can't do just as therapists delivering treatment. And we also have ways with VR to be able to capture and quantify and measure responses in a very systematic way. And these things really serve as a basis for use for VR in our current setting. Now, previously, when the hype about VR came out in the 1990s, there was a little bit of an imbalance between the expectations with the media hype and the actual technology and what that was able to accomplish. And so it was a bit oversold, and so people lost a little bit of interest. However, in the past 15 to 20 years, it has now gone from being this expensive, overhyped toy that you couldn't touch for under $20,000 to now functional technology. Skip has brought examples of being able to use your smartphone and kind of strap that on and use that as a device. There are other technologies coming out this year with Oculus goggles that are inexpensive, and you can actually, they're very portable, you know, some of them under $100. So we're seeing a lot of changes in portability and accessibility now. So there is a very unique match between the assets available with VR technology and potential uses in our field. Now, so initially it was developed to look at flight simulation, aviation field, and now you can see, you know, these fancy headsets, and you know, the idea is that people are going to be walking around, hopefully not ignoring the real world, but being able to use virtual goggles almost anywhere. This is an example of how immersive the technology is. This one is primarily visual, looking at interactivity, so using motor movements to control this game. And so again, it's interactive and it's engaging. So typical physical therapy or occupational therapy techniques that might be repetitive, might be, you know, not so fun to repeat all the time. If you engage in an interactive game, it's more interesting, and the thought that is that there might be more treatment adherence. And this is another example of a motor task. It's kind of hard to see, but his movements are reflected in a game. This is an interactive human here. This is in the autistic spectrum disorders. This allows for a job interview trainer to interact with someone who's looking for a job, and they have examples of sort of the nice interviewer, and then they have the cranky interviewer, so it gives them options and practice and role playing. Now this is a slide from, of course, what we know as America's finest news source, The Onion, showing really how virtual reality has trickled down into our culture. And here we see that the hand gestures demonstrated in the picture here transform this friend's story into immersive virtual reality experience. So the write-up briefly says, noting how the expressive movement of her friend's arms fully conveyed every aspect and nuance of the event, 27-year-old Andrea Jennings confirmed Monday that her friend Rachel Carter's hand gestures had transformed an anecdote about meeting up for lunch with a mutual acquaintance into a fully immersive virtual reality experience. From the second she started moving her hands back and forth to indicate that she was talking to Julia, it was like I had put on a sophisticated VR headset and entered an incredibly realistic computer simulation of her story. It's just trickled down into our society now. And I can't tell you how many, even Facebook posts refer to virtual reality. It's everywhere. This is an an article written by Skip and his colleagues looking at assets of virtual reality. And briefly, this is a list of what is in this article. Again, the ecological validity concerns that I talked about as being one of the weaknesses in many of our techniques in rehab and in many aspects of therapies. Stimulus control and consistency, repetition, a hierarchical stimulus delivery, so when they've met a certain challenge, then they increase that to improve skills. It can be self-guided and it can be directed at home. You can have real-time performance feedback, which is very important for feedback. You can't learn without feedback. It provides safe testing, a safe testing environment, which is important. Now, so with these ecological enhancements, we can advance in our treatments. We'll talk about that with the PTSD. Instead of relying on imaginal exposure, like the traditional therapies to treat PTSD rely on you've got to be able to bring up the trauma index in your mind. You've got to be able to relive it. Instead of having someone have to try to do that, we hear about what the trauma is, and in the virtual environment, we create a very similar thing. And we'll show some of that as it pertains to combat trauma. Also, imagine as we're trying to, in the rehab world, as we're trying to predict real-world functional performance, someone's ability to safely perform in a kitchen, someone's ability to drive, for example. It's hard to guess, how's that gonna go? We have some examples of how they did in the gym or in the kitchen. That was a training device that, in our rehab facility. But that's supervised. We don't exactly know what sorts of intrusions and distractions are going to pop up that can cause problems. Our world in rehab is very decontextualized by purpose, actually, on purpose, to be able to get a clean measure of how someone can do optimally. But in the real world, we have all sorts of distractions. And so some of the virtual reality techniques that are out there deliberately introduce distractions and interference to see how they'll perform in a real world setting. So it's much more ecologically valid. And then you can obviously throw things in that are timed and are very context relevant to increase the stimulus load and complexity as they meet prior challenges. The issue of safety is very important. Again, back to examples of at rehab, in the rehab kitchen, for example, we can teach people, look and see how they're cooking, how they're following a recipe. But again, that's supervised. It's this very safe activity. Still, injuries can happen. But imagine if you were able to be in a virtual environment and again introduce all these different intrusions. You can take people through challenges that are not safe to do in the rehab setting. For example, it's nice to work on ambulation in the hospital, but then it's perhaps not very safe to go out into the street or into a very busy street or to drive or to try power tools. And so you can introduce these environments that help to increase their ability to challenge themselves in those situations. Instead, we often kind of reserve those things for an outpatient level of goal, but often that's not even looked at. So we'll show some virtual environments, cities, shopping malls, things like that are now developed in virtual environments. So it makes it much more safe to practice these things. Now, here, basically this shows that what we're doing really is the ultimate Skinner box. We're controlling what we can, and we're measuring it, and it's a much better way to show efficacy as well. So this is how we've evolved. So now we're going to move on to some motor and cognitive applications. And as we know, you have to practice, you have to practice, you have to do to adhere, and you have to be interested to actually do what you need to do. So nobody wants to take their medicine or do their exercise. We're all looking for a shortcut but we've got to find some techniques that will actually help us adhere. Traditional therapy here. These are some videos just kind of showing, some typical OT and PT techniques here, looking at shoulder flexion and abduction, different pincher grasps and supination, pronation. And so a lot of these tasks sometimes look like preschool tasks and preschool toys, which sometimes feel infantilizing. But this is very, very typical. They get the task done. But what about game-based virtual reality training? So in rehabilitation, tasks have to be focused on specific targets, and they have to be data-driven to direct treatment. They have to be adjustable in terms of difficulty level, so something simple for one patient and then a different level for another, and you have to have challenges and be able to go up a hierarchy. You have to be quantifiable. You got to measure it and you got to show how they're progressing. It has to be administered hierarchically and repetitively, as I note. You have to be able to provide feedback to help them understand how they're doing. It has to have some relevance. It has to be motivating, or else people won't do it. So virtual reality is well suited to meet these goals. So what about games? Well, Plato well said it. You can discover more in a person in an hour of play than in a year of conversation. As we know, I don't know if any of you exercise while watching TV or trying to distract something. Games enhance motivation. Focusing on something while you're doing something that you don't enjoy so much helps. So one system for physical therapy and occupational therapy that has been developed for stroke, brain injury, spinal cord injury, cerebral palsy is this IREX system. And this is a system that uses immersive video in a slightly different way. It projects a patient's image, their real-time image, onto a screen in these engaging virtual environments, and I'll show you a couple of videos, to perform these therapist-prescribed tasks. And so they're using, just basic body movements, things that would be very kind of repetitive, maybe somewhat monotonous, and it makes it more engaging. So the patients interact with these on-screen characters, whatever the virtual environment it is. Sometimes it's a sporting environment, sometimes it's some other kind of adventure, but they're therapeutic exercises, not just games. And so there's many applications, 50 applications designed to improve movement or range of motion, hand-eye coordination, balance. And then it has this built-in ability to track progress, and it adjusts hierarchically for different levels of challenges. This is an example. And occasionally you'll see a therapist kind of pop in the background to adjust the trunk or help with movement. So there's therapists helping. But you can see it just projects them into an environment. It's more interesting than just reaching and range of motion exercises. Yeah, the sounds are a little strange, but I'm sure that can be adjusted as well. So now this stroke study from 2005 used one of the IREX system in their study, and it looked at cortical reorganization as well as locomotor recovery in chronic stroke. And so, as we know, post-stroke, underutilization of effective limbs is a chronic problem. So you've got these initial sensory motor impairments that ultimately, with long-term deconditioning lead to suppression of cortical representation of the affected limb and then further inhibits its use. It's just a vicious cycle. And traditional rehabilitation efforts have had variable outcomes, and we've not had much knowledge in terms of the neural mechanisms of locomotor recovery. So a nice neuroplasticity study. This group, Yu et al., wanted to look at cortical reorganization and locomotor recovery using virtual reality with this IREX system. And they used these 3 different tasks. There's a stepping up and down task, there's a shark bait task, and then there's a snowboarding task. Again, they're all, where the patient's image is projected into this environment. And so they had 10 chronic stroke patients, and by chronic they mean post-stroke 1 year, and have pretty much plateaued in their motor recovery. And they were assigned to either control group or to the virtual reality group. They did exclude people with severe spasticity or tremor. They excluded those with severe cognitive impairment or visual impairment as well. They also did some fMRI work, so they were trying to measure a laterality index with certain regions of interest that were thought to show some neuroplastic recovery potential. And so these are the areas that they looked at. They looked at primary sensory cortex, primary motor, premotor cortex, primary sensory motor cortex, and supplementary motor area. And so they calculated that. And they also did a bunch of motor tests as well to measure locomotor recovery. And the results with regard to motor functioning, the virtual reality group did perform significantly better as a function of the intervention. And with regard to cortical reorganization, only in this one area in the primary sensory motor cortex did the laterality index show statistical significance. But they thought that that was related to a function of the virtual reality intervention. So they concluded that the cortical activation by the effective movements in the affected limb was reorganized from ipsilateral before virtual reality to contralateral after VR activation in that area. And so they think that the virtual reality may have contributed to positive changes in neural organization. And ultimately they say, well, clearly virtual reality may augment chronic stroke rehabilitation. And they cite some consistent findings with these other studies here. So, and these other studies just had intensive use of the paretic arm. So maybe, I don't know what those studies did, but maybe constraint induced. So anyway, very interesting findings there. Then we have, this is another example, traditional exercises. These are children, but when you immerse them in these environments, you can see that they get some feedback as to how far they should be ranging, and they get different points. So this is a game, so you get more points if you do it a certain way. And if you flick the guy up higher, then you get more points. So it's more engaging, and their findings were that children could generate a greater range of ankle dorsiflexion and demonstrate better control of active ankle dorsiflexion movement. And they reported greater interest in doing these exercises when it was delivered in a virtual reality format. So it's the same type of thing, it's just more engaging, more interesting. Now, there have been studies using robot-assisted therapy that show as well that there are improved outcomes over usual care and very consistent performance with intensive therapies when you're looking at upper limb impairment. I'm just going to show you a couple of studies here. Another study with robot-assisted therapy, over 24 sessions, improved outcomes over usual care. So again, when you've got things that are engaging and tailored and feel like games, people tend to enjoy it. So here you see they've just got interchangeable virtual environments. Once you've met certain goals, it moves on, keeps you engaged. So you touch objects as they light up. It changes environments. This is a jewel mine game, which is a rehabilitation game. And basically you have different settings. And basically as your goal is to move through different areas in this island by performing tasks. So it's configurable and you have to meet certain goals. So for example, at this level, a sentence will appear at the top of the screen. Her favorite color is pink. And then you have to remember that. And then other things, you have to watch for certain items that highlight or that show up. Here you have to select words in order to copy a sentence. You have to do all sorts of things. So it's a cognitive task as well. Here you have to remember things, here you have to do opposites, and so you have to meet these goals to advance around the island. So it's engaging. Now, in this particular study looking at virtual reality and stroke rehabilitation in 2011, they concluded again that virtual reality and video game applications are novel and potentially useful technologies that can be combined with conventional rehab for upper arm improvement after stroke. And the Cochrane review says, well, there's lots of studies out there, but they're all very heterogeneous. We are challenged for the future, to better define the populations and state what our outcome measures are, and to, talk. A lot of the studies don't talk about these different types of interventions, specifically what they're targeting and the length and timing and doses of interventions, et cetera. So there's lots of challenges for the future research. The DoD and VA practice guidelines here show that ultimately, it's showing that there's promise. Maybe consider using virtual reality to enhance gait recovery, or for upper limb as in the practice context as well. So now this Connect Rehabilitation is sort of the wave for the future for home rehabilitation. I just wanted to show this. I'm not going to talk much about that, but you might be hearing and seeing more about this, engaging home rehabilitation. And the big question is ultimately, will doing this improve doing this? So you can't just be games, it's got to be therapeutic and functional. Now we're going to talk about some cognitive assessment. And this is a visual spatial task. This is a traditional task, of this mental rotation. You have to kind of mentally rotate to see, are these objects the same or different? This is the way it is traditionally done, for example, in neuropsychology. And you can't manipulate it, you just have to mentally rotate it. So you just see which one, and you have to pick which one it matches. And then now they've developed these big projection displays where this is how you can do it now. So it's much more engaging. You get the sense of that. And this particular study wanted to look at whether virtual reality techniques help people with their visual spatial skills. And so they tested them on this old mental rotation task before that visual or virtual reality task. And so pre-virtual reality, here are males and females, slight difference here. Here's how they did. They had the virtual reality intervention, and then they took this again, and that definitely improved their performance. This was a group who were lower initial performers on this particular task, and so they had a control group who did nothing, and the other group who did. The control group is red, and this was the one who got the virtual reality training. Obviously they did much better, and here they didn't do a whole lot better because they hadn't had the virtual reality training. They just did a crossword puzzle just as a control. So virtual reality training helped improve visual spatial skills here. There are virtual reality environments that help with topographic disorientation. So you can see, say you have someone who's post-stroke and they have difficulty ambulating, a virtual reality environment with joystick navigation can allow for better testing of topographic disorientation when someone's limited in their ambulation to be able to do these tasks. There are virtual environments looking at safe street crossing, and so you can practice in these environments instead of going out on the street first. Virtual cities, again, street crossing. This is an updated, better graphics. All the current graphics are much better than they were when they originally came out. Now this is a virtual office, which is wonderful as people are reintegrating back into work from their disability. And this is an initial early 2000s set of graphics in this virtual office, and I'm presenting this because in this task, they've also built in a memory test. And this is a 16-item memory test. And basically, is a virtual reality parallel to an existing neuropsych paradigm where you're testing memory. There's 16 items. In the regular neuropsych world, we just read a list of 16 words, and then the patient tells us what they recall, and then we remind them of the ones that they've forgotten. So we just tell them the ones they've forgotten, and then they have to do it again, and then we tell them again what they left out. And so this is a visual virtual reality task, where in this case, there are 8 common objects strewn about the office and 8 sort of uncommon or unexpected objects that you see. And so you're kind of scanning around, and there's a hammer and a bear and a blender and a guitar and a ball. You don't expect to see those types of objects in an office environment. But pictures and other things that were out in this side of the room earlier. And then there was, of course, the dog. And so you have to remember what there was, and then they name it, and then they go back and you scan it again, and you tell them what they left out. So basically, they wanted to find out, is this virtual reality paradigm, is it face valid? Does it do the same job as the more boring neuropsych task? And so basically, they found out that it's a face valid task. That they used 20 brain injury patients, some of whom had impaired memory, some who didn't, and compared them to healthy controls. And the results were that the virtual memory testing did distinguish the TBI group. Those who didn't, the TBI patients with no memory impairment performed just as well as the healthy controls. And there was a significant relationship between the VR Office and the standard neuropsych test. So it showed construct validity of the task. So it's ecologically valid, and I would add more engaging and interesting than the real neuropsych task. Now this is an updated, still in progress virtual office. And here you can see that it's fully interactive. You can scan around. There are different cognitive tasks that are built in. They're realistic, they're working memory, divided attention, problem solving. So distractors that you would typically find in an office, especially if you're working in a cubicle. A lot of patients have hard times going back with all the distractions, phones ringing, people talking. And so this gives an opportunity to practice that in a real world sort of way instead of just in a decontextualized fashion. Driving assessments, of course, we do outpatient driving therapists through occupational therapy at the rehab hospital, but these are some programs. Driver World is one of them, and it's got very up-to-date graphics, and so there are lots of different virtual reality environments. And I'm going to end kind of going through the pain management section because I think this is so important. Now, this is talking about acute pain management, but this applies to the broader medical setting. And there's been a lot of work in here that's very promising in pain. Now, the rationale for these VR games with pain distraction, limited capacity of attention. Attention has a relationship with pain. Pain perception requires attending to the noxious stimuli. Pain can be reduced by distributing attention elsewhere. And gaming and virtual reality techniques is one way to divert attention. So when you have a head-mounted display, it prevents visual perception of an environment. So if someone's taking blood or engaged in a painful scenario, it's a very good technique. So research does suggest that interactive virtual environment systems can be used to significantly decrease pain and reduce medications during painful procedures.
He fights that battle. Virtual reality technology lets his brain enjoy hurling snowballs to the music of Paul Simon. University of Washington researchers Hunter Hoffman and David Patterson designed the virtual reality game Snow World to occupy burn patients' minds during painful wound cleaning or physical therapy.
Snow World's the opposite of fire. Snowy, cold. It's supposed to cancel out and help distract them from remembering their original injury.
Their previous research showed that not only do patients report less pain in Snow World, MRI scans show it reduces the brain's pain signals.
Which is fascinating because you're not only just reporting it, but you're measuring that. So they've got a lot of different studies looking at pain distraction for children, and so here's a little task that they can be involved in when taking blood. They compared how virtual reality pain distraction was against, so virtual reality, the head-mounted display, just watching a flat screen or watching cartoons, or standard care, and they, basically had them rate their pain levels. So as you can see, the virtual reality had the lowest pain ratings, even in comparison to cartoons. But certainly advantage over standard care. Now here, we can translate virtual reality into a different situation where we're helping with chemotherapy symptoms. So they can be engaged in something, and there's also, when engaged, and I think the next video shows, there's a sense of time compression where a procedure that might take 2 hours is felt to be like 20 minutes, which is pretty remarkable. So how far can we go in this area? So here's an example of, dental work being done. This guy's in surgery and he's got a, head-mounted display on. So, is that possible? Who knows? But that's, certainly something that can be thought about. So research suggests that VR techniques can be used significantly to decrease pain during a lot of different clinical procedures. It persists across treatment. It's more effective, and it's than standard care, and it's very passive. And fMRI studies that got cut off a little bit also indicate less pain. Okay, so there are some virtual reality organizations, just if you're, want to follow up. There's some conferences coming up. There's one coming up in Los Angeles in September, and that's pretty much it. Thank you.